This is Health Call Online, the place for extended versions of interviews you hear in our weekly radio broadcast, the Health Call Radio Hour, appearing now on more stations around the country as they join the Health Call Radio Network. We have come to a place in medicine where we have the ability to peer into our genetic code and identify 3 factors that put you at elevated risk for cancer and cardiovascular disease. So, seems like it would be a good idea to test everyone, right? Why not find out those things? What's the cost factor? What's the benefit of all of that? Well, I found someone who wrote a very interesting opinion piece on Medscape about that. He is Dr. F. Perry Wilson, a nephrologist and a researcher at the Yale School of Medicine. And I asked him to join us today to think through that whole idea of wide-scale genetic testing, its cost-benefit, and then a lot of other technology changes coming our way in medicine and how we make sense of it. So we have a lot to talk about today, Doctor, but let's start with that genetic testing question. And give us the big picture here. What are we thinking about?
Yeah, sure. Thanks so much for having me. I'm excited to be here. So when we think about diseases that come from our genes, a lot of different things come to mind, from Huntington's disease to diseases associated with breast cancer. But there are 3 heritable conditions that the Centers for Disease Control call Tier 1. And these are things that have a gene mutation that can cause them, but more importantly than that, have treatments that can prevent the ultimate state of the disease. Because knowing that you're at risk for something is great, but unless you can do something about it, maybe you'd rather not know. Right. Those 3 conditions are people at high risk of breast and ovarian cancer. Those are genes like the BRCA gene that many of your listeners might have heard of. Slightly less well known is something called Lynch syndrome, which puts people at an elevated risk of colon cancer. And then finally, there's something called familial hypercholesterolemia, and you can kind of hear in the Latin there that this is people who have a genetic cause of very high cholesterol levels, which puts them at significant risk of heart attack and stroke. Each of these diseases are heritable. We have genetic tests for them. And most importantly, if you know that you're at risk of them, or if you know you have that gene mutation, there are treatments that have been shown to prevent the disease. So the question, of course, is, how do we decide who gets this genetic screening?
And the cost of the genetic screening is a key factor here because it used to be wildly expensive, but now, it's come down to the price of a nice night on the town with your partner, right? I mean, it's fairly affordable.
Absolutely. I mean, cheaper by the day, it seems, right? You can get nearly full genetic sequencing for not only these 3 genes, but for many, many other genes, for a few $100, and that's coming down quickly as well. The reason I wrote the position piece is because as costs are reducing, we have to grapple with this question, right? Who needs to be screened? And the current status quo is that there are recommendations to screen people who have a strong family history of one of these conditions. So to take breast cancer, for example, if a woman has a first-degree relative who had breast cancer diagnosed before age 50, we would recommend that they get screened for these BRCA mutations and other associated mutations. What was really fascinating about a new analysis that came out in a journal called the Annals of Internal Medicine was that they said, wait, what if we just screen everyone, regardless of family history? What if we get these 3 conditions and only these 3, but these 3 conditions screened at, let's say, age 30, when you still have time to make a difference? And of course, the vast majority of people don't have any of these conditions. I should just say, it's about 1% to 2% of the population who will have any of these 3 genetic conditions. So most people, if they got screened at age 30, would just get some good news, nothing to worry about, and move on. But a small percentage of the population would get news which is potentially life-changing. Think about women who are at high risk of breast and ovarian cancer might have mastectomies prophylactically, in advance of a cancer diagnosis, may even have their ovaries removed, things like that. And what the study did was it gamed out, what are the costs of all this between testing everyone, treating everyone, and how many lives will be saved by doing it? And this is somewhat complicated, but it all boils down to a number. how much are you willing to spend to extend some one person's life by 1 year? And this study calculates that this whole process would cost about $70,000 per life year saved. Now, that might seem like a lot, but actually, most federal agencies use somewhere between $50,000 and $100,000 per life year as their threshold for something that they consider cost effective, at least in this country. We probably don't have time to get too deep into the cost of healthcare in this country, but that 70,000 numbers is firmly within the range of what people consider cost effective, which means we have to talk about it.
Yeah, that's a very interesting question, and certainly, if it happens to me, it's worth a heck of a lot more than $70,000, right?
Right.
Yeah. So where does this go from here? How does our medical system look at things like this, and the Preventative Task Force take all this into account and make its recommendations?
Right. Well, this was really the first study. It's kind of the shot across the bow in this new area, which is it doesn't even have a term yet, but I'm sort of calling it, baseline genetic screening. Certainly, more studies will need to come out, and the United States Preventative Services Task Force, who are the people charged with making these recommendations, will need to integrate that information. But if you wanted me to sort of look at the tea leaves here, I suspect that we will get there sooner rather than later. Probably, certainly for these tier 1 conditions where it's clear that there's a treatment that can prevent the bad outcomes. But you might even see additional conditions added to the list of baseline genetic screening in the future.
Well, yeah, if it comes down to the cost drops to, $50, $100, I mean, It seems like, why wouldn't we do that, right?
And of course this will always be up to the individual patient. No one's going to force anyone to get genetic testing. And so there's a discussion to be had with your physician about whether it's worthwhile. And again, most people will just get good news at the end of the day. But it's like any screening test, mammogram, colonoscopy. Most people, they just do it and get a negative result, and that's good. But there's some proportion of people that it starts a whole process of medical care. And even though the outcome of that process we think is going to be good, potentially even life-saving, it's a decision that some people might want to put off.
We're at the cusp of another layer of this, and that is what's broadly known as liquid biopsy. So probably the best known example here is I submit a blood sample, and now they can test for cancer cell, DNA from cancer cells that are circulating in my blood as a signal that I have an active cancer somewhere. And one of these tests actually claims that not only can it detect the presence of cancer, but tell you what type of cancer. So we send doctors on a search to find out. What's your thinking on that?
It's fascinating technology, and anything that promises to make it easier to detect cancers earlier is going to have a good outcome, because the number one thing, no matter what cancer you're talking about, the number one predictor of survival is how early you catch it. Mm-hmm. And our screening tests for cancer, mammogram, colonoscopy, are good, but certainly during the pandemic, it became very clear that people miss those tests a lot. You got to schedule them, you have to go in, and life gets in the way. So if you can just do something as part of a routine blood test, that makes it much easier. Now, that said, they have to be accurate. And there have been some concerns about both the sort of false positive rate and the false negative rate of some of these liquid biopsy studies. Telling someone that they have a cancer somewhere when it turns out they don't, that can cause a lot of anxiety and a lot of excess testing that they wouldn't have otherwise needed to have. And of course, falsely reassuring someone that they're good to go has significant consequences as well. There have also, I think your listeners might have heard that there was a recent sort of debacle with the Grail test where they informed a few hundred people that they had cancer when they didn't. These are, I guess, technological hiccups of the worst sort. These issues will get better. I mean, the march of progress here is clearly towards more accurate liquid biopsy tests. And so once again, not yet, but I think in the future you will see this integrated into our cancer screening paradigm.
Yeah, I took the bait. I had the test. I'm an early adopter in so many things because I can excuse it as being a guinea
Research,
pig
right?
for everybody else, right? And so I was pleased to get the negative results. But in the back of your mind, there's always a wonder, is this correct? Now, the National Health System in England is studying this on a very wide scale, so we'll get some good data on all of this soon. And, of course, that makes everybody very hopeful. And then let's layer into all of this technology artificial intelligence. What do you see coming down the pike on that one?
I mean, if there's going to be anything that's more transformational in healthcare in the next decade, I can't name it. I think AI is absolutely going to change how we deliver medicine in some fundamental ways. I think of two really big places where this is going to happen. Number one, and what's already happening, is computer vision. So up until really recently, the past 5 years or so, I would bring up an X-ray on my screen and I would look at it with my human eyes and I would make an interpretation with my human brain. Or I would look at a pathology slide under the microscope and I would, again, take it in with my eyes and make a decision with my brain. What we're seeing now in the computer vision space is you let a computer look at that slide, look at that X-ray, and tell a provider like me, hey, check out this area. Something's going on here, direct my attention to that. Or potentially making the diagnosis, on their own. Now, to date, these have been used as backup systems. So if I look at an X-ray and I say, yep, normal X-ray, the system can say, hey, doc, you sure about that? Because there's something I don't like here, and those safety net systems, I think, are the first place where AI will help us because, doctors are human. We're overworked. We're seeing too many patients, during any given day. And those having a little safety net behind us, I think we can all embrace. The question is, when do people start to say, gosh, do we even need the doctors there in the first place? And, this is something doctors and I think patients will fight very strongly against. It's hard to replace the human in the room and their years of experience looking at X-rays and things like that. But as I mentioned, healthcare costs are really expensive and there's a lot of administrators with, I'll just say, no medical training who are running the show in a lot of cases and would like nothing more than to cut costs by using AI in some of these places. And I think that's something we need to watch out for a little more stringently.
Yeah, my personal belief is that a high percentage of what makes a doctor a good doctor is trusting their intuition. Experience and intuition, that's worth a lot.
There's something doesn't smell right here is very powerful. And one of the first things you learn as a medical student, as an intern, as a resident, is sick or not sick. And this is, you're going in the hospital, and we use that term it's a colloquial term. Of course, everyone in the hospital is sick, but what it really means is, should we be worried about this person or not? It's kind of the thing you say at the end of the day before you sign out to the night team. Hey, this guy in room B, he's sick. And it's said with that kind of knowing, like, we may not know exactly what's wrong here, but you've got to keep your eye on this guy. We're worried about this guy. And I wonder how fundamentally human that process is.
You have recently published a book that I just find very interesting. It's called How Medicine Works and When It Doesn't, Learning Who to Trust to Get and Stay Healthy. Trust in medicine. Boy, we are at such a fragile point in that. Just as all this technology can lead us in an exciting direction, we've got other things that are causing doubt. Give me your thoughts on trust.
It's really at a low ebb between patients and doctors right now, and I think the COVID pandemic, played a role in that.
Oh, yeah.
It increased mistrust in society, sort of all over the place, and it also really increased the rate of disinformation online. An important change that has occurred over the past couple of decades is the ability of patients to get information independent of their doctors. The internet has made it possible that when I see a patient in my office, they've already done their reading a lot of times.
They've already talked to Dr. Google.
That's right. They come in with questions. They come in even with studies sometimes that they've printed out. And in general, this is a very good thing. An informed patient is a patient you can have a better discussion with. You can get kind of deeper into the nuances of what's going on and what the treatment plan is. But it's a double-edged sword because there's a lot of information out there that is wrong. And, there's an old saying that a lie can travel halfway around the world before the truth gets its boots on. And that is very true. It's often much harder to debunk misinformation. It takes much longer to show that something is misinformation or disinformation than it does to put it out there in the first place. It's this asymmetry.
I want to push back a little bit here because
Sure.
what is disinformation? COVID really broke the system. I mean, we were told that don't worry about it, it's not airborne. Oops, yeah, now we know it is.
Yeah.
We were told the vaccine prevents infection, and oops, now we know it doesn't. Ventilators were the answer. Oop, no, they actually cause more harm. Resistance to finding out where this thing came from. People were crushed in suggesting there was a lab leak in Wuhan. Now there's lots of evidence that is a likely cause. So how can all of us be a better medical health information consumer and not just believe everything on either side of the equation?
Yeah. So obviously the communication of science is a highly important skill and one that we've learned a lot of our public health officials have not been adequately trained in.
Say that again.
One thing that we have to make clear to the public in general is that science is an iterative process of learning more and more. There is what we believe today to the best of our knowledge, and there's what we believe tomorrow to the best of our knowledge. And they may not be the same, not because we're flighty or we have just had a dream or something. It's because new evidence emerges. We have to be the more honest we can be about our level of uncertainty, the more acceptable it is when we come back later and say, gosh, we thought it wasn't airborne because, most viruses like this wouldn't be, but actually it really looks like this one is. And, we took our best guess and we had some evidence to support it. And now we have even more evidence that suggests it is airborne. One of the problems is that the current media environment rewards certainty over nuance. Mm-hmm. And so I think one of the reasons these well-intentioned public health officials will come out and sound very certain about things is because even if they don't acknowledge this consciously, they feel that they are competing against the high level of certainty on the, quote, other side, right? And so if one side is saying, this is absolutely a bioweapon from China that was released deliberately to destabilize the West, okay, this highly certain comment. And I'm someone who has looked at the evidence and says, no, I don't think we have any we don't have evidence to go that far. There's this temptation to say, well, I've got to take a kind of certain sounding position just to offset all the craziness on the other side. And we have to be comfortable embracing nuance. One of the things I talk about in my book is that a doctor that you go to that is willing to admit that there is nuance and that there's risks and benefits of medications, there's harms, and that essentially medicine is a process of hedging our bets, where I'm giving you my best advice. Can I guarantee it's going to cure you? No, but I think it's better than doing nothing. That's actually a good doctor, as opposed to kind of the doctor you see on TV that says, like, I've got the diagnosis and here is the cure. Yeah. And I tell people when they're consuming stuff online, certainty and emotion are red flags. If you read something about medicine, health, wellness online that says that they are sure that A, B, or C is happening, or if it's being sold with anger or sold with, an appeal to emotion, right? A loved one is dying and then is saved. These are real red flags, because the truth is medicine is a very fuzzy science where, it's not astronomy where we can measure the distance to the star, with high precision. What we're saying is, in general, when we treat people like you with this medicine, on average, more people do better than when we don't treat them with this medicine. That's, I understand, not compelling in a tweet or in Facebook, but that's the reality of the situation. You want to gravitate towards people who can communicate the reality in that way.
Wow. I think that's great advice for all of us health consumers to swallow. Let me ask you this. I love asking these questions of people like you, guests like you. You've studied far more research than I ever will. What health habits have you now acquired? Are there supplements you take? What do you do to stay healthy that we can all learn from?
Oh, well, so there's a chapter in my book that is about what I call one simple thing medicine, which is another red flag, which unfortunately is this idea that there's one thing you can do, one supplement you can take, one, to get thin or to improve your memory or one special exercise you can do in 2 minutes a day that it's going to give you 6-pack abs or, one food that you can eat to prevent cancer.
Find the one that grows hair. Would you do that, please?
Yeah,
that's the one I need.
I'm starting to need that one as well. And the truth is there really is no one simple thing. It may be putting quitting smoking aside, but that's not very simple to do, honestly. Most of the things that are going to change the trajectory of your health over time take some amount of effort. And this is true, the pharmaceutical companies also want you to think that there's one simple thing. They want you to think that their antidepressant pill is, one easy pill, take once a day and you won't be sad anymore. This is also not true. Real change in health requires effort, like everything in life. And so, one of the places that has certainly changed my view of things, one of the research is exercise, has benefits not only across the cardiovascular system and the brain, but also psychologically, but actually takes a little bit of work. You got to get out there. This 30 minutes a day, 5 days a week is not easy for most people. Mm-hmm. But that's something that I try to abide with. I've got a trusty dog that goes on my runs with me every morning, and I try to do that. Weight loss is a very powerful tool to improve health. It is also not easy. And anyone, saying that they have a simple supplement or something that's going to help you lose weight is almost certainly selling you something. They usually are. And so when we talk about weight loss, when I talk about weight loss with patients, I say you got to put the work in. We do calorie diaries, write down what you're eating and count calories and all that kind of stuff. Obviously, get some exercise and avoid all the processed foods and the fast foods and the things that make life easier, because all of these big changes take effort, and we're all sort of averse to effort, myself included. We all, given the easy path and the hard path, we all just kind of want to take the easy path. That's normal. But for health, you got to be willing to put a little work in.
Okay. I didn't hear an answer to the original question, though. Are there any supplements that you take that you've found enough evidence for and enough belief in to make them a part of your life? No. The
answer is
vitamin D, nothing.
No, especially not vitamin D.
All right. Now we're going to branch another topic.
Oh, no. So I'm an anti-vitamin D person.
I'm surprised to hear that.
Yeah. No.
Well, you're a nephrologist, so I understand. So I get that, right?
I do a lot of work with vitamin D and nephrology. And let me say this about vitamins and supplements. If you have a deficiency of a vitamin or a vitamin or a mineral, then by all means you should be replenishing that deficiency. But most people don't. You eat a varied diet. You get out there in the sun in terms of vitamin D. Most people won't have a deficiency, and so something to talk with your doctor about. The addition of additional supplementation beyond what you'd get in a varied diet probably has no effect. Now, the reason vitamin D is so hyped is because vitamin D levels go down the lower your health status is. If you don't get out in the sun as much, you don't get as much exercise, you don't eat as varied a diet, you're overweight, you have higher inflammation, etc. No matter how much vitamin D you're taking in, it drives your levels down. So in studies that look at level of vitamin D and health outcomes, lower levels are associated with more cancer, more death overall, more cardiovascular disease, more dementia, more COVID. I mean, anything you can think of, because vitamin D level is a marker of overall health. But when you move into randomized trials and you say, let's take a group of people and half of them will give vitamin D and half of them we won't, and see what happens, there's almost never a difference. So vitamin D is a canary in a coal mine. If your vitamin D level is low, or it may be telling you, something else is wrong, we need to think about this and explore what else is wrong. But the supplementation of vitamin D, boosting your vitamin D levels up higher, particularly in people who aren't low to begin with, has never been shown to change those long-term outcomes. Again, it's one simple thing. It's easy to take a pill of vitamin D, but most simple things don't change very much.
Fascinating. Love hearing your thoughts on that one.
I know I'm a little heterodox on vitamins and stuff, but it is what it is.
I've really enjoyed talking with you. I'm going to circle back. We will connect again. I hope you don't mind if I throw some other topics at you and probe your brain on all of this. Sounds like
Anytime.
You are very well-read, very open to new thoughts. So I'd love to hear the thinking of guys like you. So thanks so much.
That's the goal. Thanks for having me. Really had fun.